Jonathan Wang, the founder of the Youth Advocates for Global Health Association. We are a youth-led nonprofit organization, and our vision is to establish a united global youth community committed to advancing global health equity and fostering human health and well-being. Through initiatives centered on research, community projects, public advocacy, and international engagement, we strive to shape a healthier, more equitable future for all.
Good afternoon, everyone. My name is Matthew Yu, the Vice President of the Youth Advocates for Global Health Association. Today, we will be exploring the topic of new technology and its role in bone replacement and limb salvage. We're excited to speak with Dr. Darius Viskontas, an orthopedic surgeon at the Royal Columbian Hospital in Westminster and the Eagle Ridge Hospital in Port Moody. Dr. Viskontas received his fellowship training in orthopedic sports surgery at the Adidas Sports Medicine Clinic in New Zealand, knee sports and joint replacement surgery at the Royal North Shore Hospital in Australia, and orthopedic trauma at Harborview Medical Center at the University of Washington, Seattle. He specializes in orthopedic trauma and surgery of the lower extremity, as well as athletic injuries of the knee meniscus, ligament, and cartilage, and degenerative conditions. Dr. Viskontas is also a clinical professor in the Department of Orthopaedic Surgery at the University of British Columbia, but we'll wait for him to tell us a bit more about himself.
Following the presentation, we will have a Q&A period where all webinar participants may submit their questions using the chat function. Without further ado, let's give a warm welcome to Dr. Viskontas. Thank you so much for joining us today.
Thank you very much, Jonathan and Matthew. It's a pleasure to be here. So I thought today I'd talk about a topic that's very interesting to me and that we see a fair bit of at the Royal Columbian Hospital. The Royal Columbian Hospital, we do a lot of trauma. We're the busiest trauma center in the province, actually. And so we see a lot of trauma from the highway. There's a lot of industry in Fraser Health and up the valley. So we see industrial accidents and then sporting accidents. And so unfortunately, a lot of these motor vehicle collisions lead to patients who have severe fractures and the current technology in trauma allows patients to live now, and especially things have changed with cars, where cars are much safer and people wear seatbelts and we have airbags. So people survive high energy trauma, but one of the challenges is to try and reconstruct their limbs because their limbs often see a significant amount of force that can lead to severe fractures and wounds. And so one of my interests is limb salvage, particularly the lower limb. And so within our trauma group, I specialize in pelvis and lower extremity trauma, although I operate on upper extremities as well. And so today I thought I'd discuss internal bone transport. And over the last decade, there's been some new technology that has helped to revolutionize this treatment. As I go, if anybody has questions, I'm happy to also answer as we go. So just in terms of disclosures, I do not have any financial disclosures that are relevant to this presentation. I am a shareholder in a company called Precision OS, which is a Vancouver-based company, and they create models for surgical education using virtual reality. I do some educational consulting for a company called Synthes, which is a very large orthopedic company. And then I've received some research funding for studies that we've done through the hospital. So I'll talk about traumatic bone loss, specifically of the tibia, since that's more common than in the femur. Some of the history and the evolution of this treatment, and then some of the current strategies that we use to reconstruct limbs. So here's a case example. This was a patient of mine. He was 35 years old. He's healthy, and he was on an e-scooter, and this has become quite a popular mechanism of injury, unfortunately, with the evolution of e-scooters and their popularity and use. And they do go fairly fast. People use roads on e-scooters, and unfortunately, often there are crashes, and this can also involve motor vehicles. And because of the position of the rider on the scooter and a bumper, often the tibia is involved as the bumper hits the lower limb. And so this patient had a severe injury to the tibia. On the right is an X-ray of shattered tibial bone. So the tibia is the bone in the lower leg, and there's a smaller bone called the fibula, but the tibia is your shin bone essentially. And he had a very large open wound. Sorry, it's a bit graphic, but just so that I can illustrate the severity of this injury. And so initially, when a patient like this comes to the Royal Columbian Hospital, there's a trauma code, and a trauma team assesses the patient. They look for other injuries, specifically head, chest, abdomen, and pelvic injuries. And then as long as the patient's resuscitated and they're doing well, then we proceed with extremity injuries. And so patients are often resuscitated with fluids and blood whenever somebody has an open fracture. So an open fracture is a fracture that's come out through the skin. The patient is provided with antibiotics. It's been shown that the earlier we give antibiotics, the lower the chance of infection, which is a very significant problem with this type of injury. Their tetanus status is updated, especially in adulthood when they haven't been re-immunized for tetanus. That needs to be done every 10 years. You should have a repeat tetanus shot, but we often do that in trauma scenarios with open fractures. And then the limb is washed and splinted. And so once we have the initial resuscitation and the patient is stabilized and either they go to the intensive care unit or to the ward, then we need to start thinking about how to treat their limb. And specifically in the lower leg, when somebody has a very severe injury like this that involves bone, potentially bone loss, and a severe soft tissue injury, we start having a conversation about limb salvage versus an amputation. And although an amputation may seem extreme, there have been a few studies that show that patient outcomes after 2 years or more from the time of injury can often be quite similar, whether they have an amputation or limb salvage. But from an emotional perspective and psychological perspective, patients have a significant difficulty making a decision to have an amputation early on, because often, their leg was fine prior to the injury that occurred a few hours ago, and now we're suggesting that we remove their leg. So often there's a time period where we have to proceed as though we are going to save the limb, and then sometimes things evolve, such as soft tissue healing problems, or infection, or if patients have comorbidities such as diabetes or they smoke. Those are all factors that lead to problems with healing and can lead to an amputation.
Yeah, it's always difficult to go ahead with an amputation, especially because it's a body part that you've always had. It can be extremely psychologically damaging, but it sometimes is necessary to save you.
Yes. For limb salvage, the discussion that's had is that, when patients have a severe injury, it can take several years in order to achieve a full reconstruction of their limb. And so, and it usually requires multiple hospital admissions. They typically have at least some type of complication along the way, and they often are left with chronic pain and joint contractures. And so, functionally, we have to discuss realistic expectations when somebody wants to maintain their limb. And sometimes patients actually do better with an amputation, and they get back to life and work quicker, which can be a significant impact for them, both morally and financially. So with this patient, we decided to proceed with limb salvage, and so we brought him to the operating room. His tibia was fixed, and so his post-surgical X-ray is on the right side. He was treated with what's called an intramedullary nail. So we put a titanium rod within the bone. So the tibia and the long bones in our body are like pipes. And so there's hard bone on the outside and soft bone on the inside, which allows us to treat these fractures with a rod that can be placed within the bone. That rod is very strong. Often patients can weight bear with it. It helps to realign the fracture, and it's reasonably minimally invasive. If you look closer here, in the middle here, I think I made a little circle. This area here was an area of bone loss, and this white is actually bone cement. So this patient was missing this part of the bone. And so sometimes what we do is to fill that gap temporarily, we put in a special type of cement that we use. In orthopedics, we put antibiotics within the cement to try and help prevent infection. And then he had a augmentation with a plate here. That's not structural so much as the plate was used for initial alignment before the rod was put in, but then it was left in just to help bridge that gap. So, here we're left with a limb that appears well aligned. However, he has this large defect in the bone that will need to be dealt with. But prior to dealing with that and getting that to heal, he needs plastic surgery. And plastic surgeons help us cover soft tissue defects. And because this patient had a significant defect in the mid aspect of his leg, the plastic surgeons took skin and subcutaneous tissue and fascia from his thigh with an artery, and then the artery gets put into one of the lower leg arteries, and the tissue is used to fill that defect. Once that's healed, then we can proceed with our bone reconstructive procedures. But typically, until we have soft tissue coverage and we know that it's going to survive and be viable, you can't really do much with the bone. So, what are the options? So now he's healed his flap. He's doing well. He's healthy. He's young. He wants to maintain his leg. His knee and ankle joints are good. So he didn't have significant injury to the knee, ankle, or foot. And so really we have this defect in the middle of the tibia to deal with. And so, this is a perfect candidate for limb salvage because his joint above and below the main injury site is functioning well, and so he can typically achieve good function if we're able to restore bone in that location. And so generally the options are we can either bone graft that area or we can do what's called a bone transport. And bone grafting typically consists of taking bone from somewhere else in the body and applying it to the area. Sometimes we have to augment with donor bone, which comes from a cadaver, just like organ donation. There are some synthetic bone grafts that can be used. And a bone transport procedure is where we move bone from one location to another. And so the challenges with the tibia specifically are that the blood supply to the bone is somewhat poor compared to other bones in our body. So first of all, the lower extremity blood supply is not as good as the upper extremity. So upper extremity fractures typically heal very well. There's good soft tissue coverage. There's very good blood supply in the upper limb, whereas in the lower limb, it's typically not as good. Blood supply to the bone comes from arteries that come into the bone, from small arteries that come from surrounding musculature to the bone, and then there's an intraosseous supply. So blood runs through the center of the bone, which also supplies blood to bone cells. But when you think about the tibia is just underneath your skin, so you can feel your shin bone just underneath the intramedial aspect of your lower leg, which is sort of the inside front portion of the leg. And this is an axial image here. And so this yellow part is the tibia. This is the fibula. So this is a cut right through the center of the lower leg. And then all this red stuff is muscle. And you can see that, the tibia here is right underneath the skin. And so the blood supply to this area is relatively poor compared to the blood supply in the back or the posterior aspect of the tibia. And so this is a significant problem for healing, because we need blood supply in order to heal fractures or to heal bone. And also to fight off infection. So you can, typically infection is treated with antibiotics, but if the blood supply to the bone isn't very good, then the antibiotics don't get there, and the bacteria can flourish. The other interesting, the other reason why people often have problems with open fractures of the lower leg are because the tibia is so close to the skin. So, it doesn't take much before this bone penetrates the skin when it's fractured. And you can imagine as the bone is breaking, you get sharp bone ends, and they can come through the skin fairly quickly. There's also a lot of soft tissue stripping that occurs. So when people have a fracture, the tissue gets stripped off of the bone ends, and that tissue, specifically the periosteum, is a fibrous tissue right around the outside of the bone that provides a significant amount of blood supply to the bone. And if that gets stripped, then the bone ends can die, and that creates problems with bone healing. So these are all the challenges that we have to deal with in the lower leg, and we don't see as much of this in the upper segment, such as in the femur or your thigh bone. So bone grafting, works reasonably well. It typically works better for smaller defects. This is a little bit of an extreme example, and you can see on the left side, this cloud is some bone graft that was placed in this defect. And then eventually it matured. And for this patient, this worked out very well. This is sort of a lucky go for this person. It often does not work as well, especially if you have soft tissue compromise. And even though we have plastic surgeons cover, a soft tissue defect, that flap doesn't provide a lot of blood supply to the particular location of bone damage or bone defect. And so with this patient, because their soft tissues were good, they healed their bone graft pretty well. But again, this is somewhat unusual. There's another option where you can take part of somebody's fibula, and we have plastic surgeons help us with this. And they take an artery with that portion of bone, and then it can be inserted into the tibial bone defect, and it will heal. And they also take an artery from the lower leg and then plug it into that piece of fibula, and that fibula will heal to the bone ends and remodel. But the results of this procedure are not all that reliable. So there's another technique called bone transport, or sometimes referred to as an elevator technique. And so what this refers to is, if you look at this image on the right, if we have a defect in the distal tibia, so the lower portion of the bone, you can put on a frame to stabilize the leg, and then you can make a cut in the proximal or top portion of the bone. And if you move this bone slowly, the bone behind it will fill in, and then you can use that bone to fill this whole defect. And you can see it's illustrated in this image where the bone gets moved down or transported, and eventually it fills in at the top, and then you get it to heal at the bottom. And so it's called an elevator technique here because we're moving bone from the top to the bottom, or you can do it retrograde, you can move it the other way around, or you can do what's called a bifocal transport, where you can cut the bone in the middle if you have two defects and move up and down. So it can get quite complicated. Historically, people used frames to do this, so external frames to stabilize the limb, but there is some technology now, and this is specifically what I'm going to bring to you today, where we can use internal devices to move this bone, and this has become quite interesting recently. So this technique is based on something called distraction osteogenesis. So bone, so for instance, when you have a fracture, there's trauma to the bone and you get bleeding. That bleeding, the blood turns into a jello type of consistency, which is called a hematoma. And within that hematoma, there are a lot of growth factors that help bone heal. And so those growth factors will help to allow the bone to heal, but during that period of time, you could start distracting the fracture. And if you do it slowly, then the bone will still continue to heal throughout the period of distraction, and eventually it'll remodel, and that gap will calcify and turn into bone. So this is sort of the principle where we can cause a fracture in the bone, and that's called an osteotomy. And so where we cut the bone, there's techniques for that, but let's just say you cut the bone, so you're causing a fracture, which then leads to hematoma and growth factors in that area. And then if you distract it slowly, then you can get it to heal in as the segment's moving. And this was pioneered by a Russian surgeon. This was in Soviet times. His name was Elizarov. And so these ring frames are called Elizarov frames, and the technique is named after him. And he worked in Siberia in a town called Kurgan Oblast. And in 1951 is when he started to realize that if you stabilized a fracture and distracted it to realign it, then it would heal. And so he was putting frames on people at the time in order to help heal their fractures and gain alignment. And then eventually he used that for deformity correction. And so it's interesting because this was sort of based on horses, and the shaft bow is the connection of the shaft to a wagon or a sled, and the bow that's applied to the horse. And the horse would be pushing on the bow, but that applies a tension force to the shaft. And essentially what's happening with this frame is that you would initially he started using half rings, or it kind of looked like a bow with another ring at the other end, and he would then distract the fracture between the two rings and apply metal rods between the rings to hold them there. And then eventually the bone would heal, and the fractures were better aligned rather than putting people in a cast where fractures often healed short and angulated. And at the time, they didn't have all these rings that are now produced by manufacturers. So they were using bicycle parts and spokes specifically. And if you think about a bicycle wheel, the wheel in and of itself is not that strong and the spokes aren't that strong. But if you apply tension to the spokes, then it makes the wheel very strong, which can support hundreds of pounds. And so this type of fixator, or we call them external fixators because they're external to the body, they can be very strong and powerful, and patients can weight bear on these rings. And so typically the rings are attached with small wires, or what's called a half pin, to the bone, and then we tension these wires, and then it creates a very stable construct. So it works quite well, and you can use the bone transporter elevator technique to move bone. And you can see in this illustration here on the left, there's an osteotomy. So the bone has been cut or broken at the top. And then this frame is used to move this segment of bone. And you can see in the second image here that it's moving down the leg, and it's filling in, the bone's filling in behind that segment. And then eventually the frame can be removed, and you've created all this new bone. However, patients have to wear this device for a long time, and there are problems with it, other than it being uncomfortable. And so the Elizarov technique evolved, so about 2 decades ago, this was sort of in the 2000s, another surgeon, orthopedic surgeon, and his brother, who was an engineer, came up with a frame based on some engineering done by NASA, where they use a hexapod. And if you have a hexapod with 6 struts that are angulated, you can move it essentially in any plane. And so this simplified some of the Lizaroff frames, and they added a computer software to this frame. So what you could do is apply the frame to a leg. You could put in the deformity into the computer software and then tell the computer to straighten the leg, and the computer would then print out this prescription for the patient. And you can see on the top, it has different colors, and there's 6 struts here and the date on the left. And so the patient could then turn each strut every day on their own, and eventually it would either you could do a bone transport or a deformity correction and use this frame to help save their limb or to correct a deformity. But again, problems with these frames are that they're cumbersome, so patients have to wear them for a long time. It's difficult to put pants or clothes over top of frames. I've had multiple patients get quite creative about what they would do to wear these frames. They don't like the frames because they're uncomfortable. It's difficult to sleep with them. They can walk with them and weight bear, but often it hits the other leg, and so it can be a nuisance. They almost always get pin tract infections, so these pins are coming through the bone, through the skin and into bone, and so you can see there's some pus around these pin sites, and so we don't even consider that a complication of wearing this frame. It's just we just know that that's going to happen. So you typically can just be treated with antibiotics, but sometimes you have to revise the pins or revise the frame. It causes a lot of pain. People are on a lot of pain medication often when they're wearing these frames, which can lead to issues with narcotics. And then patients can also get contractures of their foot because it can be painful to move the foot and ankle. And so they can get a contracture, which can be difficult to solve once the frame comes off. And although you may save the leg, they may not have a very good functional foot in the end on which to weight bear. A simpler way to do it is to use a monorail frame, and so this can be used in addition with an intramedullary nail, and so this frame's a little bit simpler. It also allows you to ensure that the bone comes down where it's supposed to. So one of the problems with the ring frames is sometimes the bone would drift, and so you'd end up transporting the bone, but it'd be off by a bit, and then you'd have to go back and revise it to fix that. But with a monorail frame, because the bone is being moved over the rod, you're in a much better position to bring the bone down where it's supposed to be, and it's a bit of a simpler frame. Easier to manage, a bit easier for the patient and the surgeon. But over the last decade, there's a company that came out with some intramedullary nails, and this was mainly for children initially for limb lengthening. And so there are entities that children get where they end up with limb length discrepancies. And so this company created a nail that's basically a nail within a nail. So if you look in the top right, you can see that this segment is smaller and slides within the larger segment, and there's a magnet in the nail, and then there's an external magnet. And so patients can apply the external magnet to their leg, which then turns a motor in the nail and pushes the inner nail out. And so by doing that, you can then lengthen a bone. So here you can see, the technique again is similar to just a trauma nail that we use, but on the right side, this is the lengthening nail. And so a cut has been made in the bone, and this part of the nail is moving distally and creating length in the tibia, and then the fibula is following. And so now you don't need an external construct, and so it makes it far easier for the patient and significantly decreases the complications that we see with external devices. And so again, the rod is put in the tibia. There's a magnet. So, and we find that magnet, we can see it when we use X-ray in the operating room. So we mark where the magnet is so the patient knows where to apply this external magnet. And there's a little window in the magnet. So they apply the external magnet in the particular location where the magnet is in the nail. And then they can lengthen the tibia or the femur. And again, we do it slowly, and that allows bone to grow in behind where we made the osteotomy. And so this device then started to be used for bone transport and not just lengthening. And so the only problem was that because we're filling a defect, we needed to hold the distal part of the tibia to the proximal part of the tibia while the middle part gets moved. And so a technique called plate-assisted bone transport was devised where we could put a plate with some screws to hold the distal portion to the proximal portion and then use the lengthening nail to move the middle segment down as illustrated here. So then the company came up with a transport nail. And so now this has made it even easier. And so this is just like a trauma nail where the nail extends from the top of the bone to the bottom of the bone. And if you look on the right, they created these slots in the nail. And so when we make an osteotomy or we cut the tibia at the proximal end, we can fix this middle segment with a screw in the slot, and then that screw pushes this bone down with an internal motor in the nail, and that screw slides in this slot, and you can recalibrate it. So here's a hole for the next part. It can't be too long, otherwise you significantly weaken the nail. So they have two slots. So you have to bring the patient back and move the screw to the next part if you have to keep moving it. But it allows you a significant amount of length for transport. And so essentially that's what I did for this patient. So again, he has this defect. Oh, sorry. So he has this defect in the middle in which there was cement. So that cement was removed. So here you can see his defect. It's about 10 centimeters, or we often think about it in millimeters because we need to move this segment very slowly. So typically in the tibia, we can move it by about 1/2 to 3/4 of a millimeter per day. So I made the osteotomy up here in the top of the tibia, and then I moved this segment to fill this gap. And you can see here we are at time 0. So we're just starting to move it. So we usually wait 7 to 10 days after the surgery to allow some healing to occur at the fracture site or osteotomy site. And then the bone starts moving. And again, this patient is just doing this at home. Every day he puts the magnet on his leg and he's slowly moving this segment down. And so you can see there's a little bit of cloud forming up here, and that is new regenerate. And this fragment keeps moving, and so it took around 6 months to move it all the way down. And I ran out of nail excursions, so ideally we would have moved him another centimeter, but I brought him back. I put some bone graft because now it's just a small area to bone graft. So I bone grafted it. I put a plate on here so that this segment wouldn't pop back up, which unfortunately can happen. And now we wait for this regenerate to consolidate. And by 15 months from his initial surgery, you can see that this is all filled in with bone, and his bone graft has healed. And so now he has a new tibia. There you go. Great success. So in conclusion, tibial bone defects are a difficult problem to deal with, and there's a high risk of limb loss. there's high patient morbidity with salvage. Lots of time going back and forth to the hospital. They're off work. They have multiple surgeries. But this current technology of all internal and intramedullary nail bone transport has significantly improved our success rates, lessened complications, and made it significantly easier for patients. So thank you very much.
Thank you, Dr. Viskontas, for that very insightful presentation. Before we get into our Q&A session, I did have a question regarding like this is a very revolutionary type of treatment for limb salvage. But what are some reasons why a patient might not be a good candidate for this technique?
We look at patient age. So younger patients have a better chance of healing. We go through their comorbidities, so other illnesses or diseases that they may have. So diabetes is a risk factor that can be problematic. Patients with diabetes often have vascular disease, which affects blood supply. Peripheral vascular disease is an issue. Smoking affects vascular supply. And sometimes patients are on medications that can affect it. So if they have an inflammatory or autoimmune disease, or if they have cancer and they require chemotherapy, these types of medications are bad for wound and bone healing. And then sometimes patients can't, we need soft tissue coverage. And so if they don't have good soft tissue coverage, then typically this will fail. And also they need an intact foot. So sensation is not as important. We used to say that if you did not have plantar sensation, so it means sensory function to the bottom of your foot, you can't feel it. So when I was training, that was sort of an indication to do an amputation. But we don't use that so much anymore because patients can still walk on a foot they can't feel. Although it makes it harder, it sort of feels like your foot's asleep all the time. But if they don't have a good functioning foot, then again, doesn't matter what you do in between the knee and ankle. If the foot's not viable or good enough for them to weight bear on, then that would be an indication to proceed with an amputation rather than salvage.
Wondering how can AI or sort of new computer technology, 3D printing, I don't know, play a role into this new technology in bone salvage and bone transport?
I don't know the answer to that question yet. I mean, AI may be helpful in determining, which patients may have a better chance of success with these treatments. These treatments are expensive. These rods are expensive. And so, especially in our healthcare system, it's a problem to obtain these rods because they're very costly. And then, if it doesn't work and if that could have been predicted, then that, can be a cost savings to our healthcare system. So if AI could be used to help determine which patients may have, a successful outcome, then that will be very useful. Also, the technique is not, although you may think it's very accurate, there's a lot of kind of error. So sometimes the magnet gets programmed to move, the external magnet gets programmed to move the internal magnet a specific amount every day. And so if we program it to move a millimeter, it doesn't always work out that way. And so sometimes we don't know if that's because the magnet's not being applied to the leg in the proper position, or if there's a lot of tissue between the external and internal magnet. This is more, we see this more in the femur, for instance. So if somebody has a very big leg, the external magnet needs to turn the internal magnet, and sometimes it's not overly reliable. So maybe AI could help to let the patient know that they have to reposition the magnet, or push down harder on their tissues in order to allow the internal magnet to function better.
Absolutely. Another question we had was how do you determine which patients are suitable candidates for limb salvage with all internal bone transport versus just simply amputating the leg?
Well, again, so this goes back, to patient-centered care, and so there are specific factors that if you can't reestablish blood supply to the foot and the foot's going to die, that's a pretty clear indication for an amputation. If they have no neurological function in the foot, they could still potentially have a bone transport, but their foot's not going to be as functional for them. So then they may be better off with a prosthesis. If you can't achieve good soft tissue coverage, again, for the reasons that I mentioned previously, typically that's either secondary to the trauma or the size of the defect, and then patient comorbidities. If you can't cover the bone with soft tissue, then you can't do a transport procedure. And then often it's just, having a discussion with the patient and indicating to them that, their option is either to have an amputation, and with an amputation, patients now are typically walking with a prosthetic within about 2 months of their trauma, whereas with the limb salvage procedure, for instance, when you're doing a transport with a nail, you can't let them weight bear. So, this patient, this example that I showed you, the patient was basically on crutches for nearly 2 years while this was done. So if patients have, family to take care of, they can't, they have a job that requires them to stand or walk or lift or climb, then those types of things may preclude them undergoing a limb salvage procedure.
Mm. Yeah, thank you for that. We also know you're, a sports orthopedics. You've worked with some athletes before, and I know a lot of, of our viewers are athletes as well. So, how do you see this new technology impacting sports medicine or athletes with serious injuries? Have you worked with any athletes with super serious injuries? Could you tell us a bit more about, the athletic sort of applications?
So, unfortunately, these types of injuries are often, um, they cause significant compromise in terms of people's athletic abilities. Now, that being said, people can rehabilitate, and we hear through social media and on the news often Paralympians or Paralympics, sorry, there's lots of people who do very well with prostheses, and the technology with prostheses has significantly improved. And if you have the financial means to obtain a good prosthetic, uh, then you can do very well with that. In terms of, salvage, even though these patients, we can save their tibia, they typically end up with some degree of pain in that limb. And, it's a little bit unpredictable as to how much pain they'll have, and pain is very subjective, and people's ability to manage pain varies from person to person significantly. Um, but it does become more difficult for them to resume, high-level sport when they undergo a limb salvage procedure.
Thank you for that. I just have had a question about how often patients would need a second surgery or revision after this procedure. Like what usually causes doctors to go back in to fix or adjust something.
Well, so, like for instance, for this patient, he had his initial trauma surgery. Then he had surgery with a plastic surgeon to cover the leg. Then I took him back to put in the transport nail so that and to prepare him for the transport and cut his tibia, do his osteotomy. So that's 3 surgeries there. Then I had to bring him back to change the position of the screw in the nail, because the way the transport nail is designed, you can transport 30 millimeters initially and then another 70 millimeters, but you have to move the screw. So that's a small surgery, not too big, but that's a fourth surgery. Then I had another issue that I didn't go into here, but when I ran out of, I still needed to move him a bit more, so I had to get a little bit creative, but I had to bring him back to sort of give myself some more transport room. So he had a fifth surgery, and then I had to take him back to, so once you bring that transport segment down, you need to bone graft. It's called the docking site. So where the transport segment hits the distal segment, you need to bone graft that area. So that was a sixth surgery. And his flap was big. So often when the plastic surgeons put the initial flap on, it can be quite big and cumbersome. So he just had another surgery to make that flap smaller. So that's a seventh surgery. And then this nail, because it's magnetic, the manufacturer recommends that the nail be removed, because we don't know the long-term effects of him having a magnet in his leg. So that'll be his eighth surgery. And he didn't really have any significant complications. So that's, eight surgeries within about 3 years. And that's pretty standard actually. So if he had a complication, like let's say he got an infection, or sometimes, there's a technical aspect, like I've had a screw back out and you have to put it back in, or sometimes I use this to fuse an ankle. So if their fracture is more distal, they don't have an ankle joint anymore, I can still do a transport, and I transport the segment right down into the foot, but the foot is harder to hold with the transport nail. And so sometimes the screws loosen and you need to revise it. And so, I have a patient right now that I'm working on, and he's had multiple surgeries, and a lot because of infection. And so, um, so yeah, so those are some of the reasons why you have to take them back.
Yeah, being in orthopedic surgery is really a lot of work, and you're operating on so many patients and multiple times. So I was wondering, how did you develop an interest in orthopedic surgery? We were a bit more curious in learning a bit more about your story. That was also one of the questions we got in the chat. So maybe tell us a little bit about how you got into this, your interests.
So my interest actually in medicine started in grade 9. So in health class, we were shown a documentary on artificial mechanical hearts. And so I thought it'd be interesting to become an engineer and then build hearts and put them into people, engineer, cardiac surgeon, and then so that was my plan for the first part of high school. And then I started to develop problems with shoulder dislocations. So I was playing basketball and I had multiple shoulder dislocations, and I had to have a surgery on my shoulder when I was in grade 12. And I was lying in the operating room waiting to go to sleep. And, I saw all the tools that the orthopedic surgeon had. And I've always liked working with my hands. And when I was growing up, I used to um, help with renovations around the house, and build a tree house. And I always like doing things with power tools and my hands, and wood. And so I just found it fascinating that, that the orthopedic surgeon could fix my shoulder, and it was quite mechanical. And so then I started to look into that a bit more, and I did some volunteering at the hospital, and saw what orthopedics is all about, and met some orthopedic surgeons. And so it was always sort of a goal of mine to become an orthopedic surgeon. In medical school, I tried different types of surgical specialties. I knew I wanted to do something surgical, um, but I always came back to orthopedics, and so in the end, I decided that's what I want to do, and I'm very happy with my choice to this day.
Yeah, thank you for sharing that. It's very inspiring to hear how that your journey in finding a career path evolved like that. How was it like working and training around the world in places like New Zealand, Australia, the US, and Canada? Like what has it what do you feel like it has shaped your practice today?
Well, so I think it's very important to try and educate yourself globally, because you get different perspectives. You work in different environments, you work with different people, and so I think it was very helpful for me to see how things are done. And I mean, there's a lot of similarities, and I worked in the Western world during my training. Um, but the healthcare systems differ, and so it's very enlightening to see how people do things in different parts of the world. And I would encourage everybody, with any type of career choice, to try and work elsewhere, and live elsewhere. So not just go for 3 weeks. Like, that's a nice thing about fellowship in medicine, is that you go for 6 months or 12 months, and so you do get to live in a different part, and it's good to take advantage of that.
Yeah, I definitely agree. A lot of young aspiring healthcare professionals, they're all the peers that we work with, we're all also thinking about, where we want to do in the future, what university you want to go to, do we want to go across the world, which parts of the world we want to go to. So I think it's always, very enlightening to hear that it's good to discover new perspectives around the world. Now, speaking
Yeah,
of that, I was
can I
wondering,
just say one thing? It's
yes.
harder. People sometimes say, well, I'll travel, like, when I'm done or working, but it gets a lot harder once you have a job. It also gets a lot harder once you have a family. But also when you're educating yourself, you can often get an educational visa. And so in a lot of countries, you can't stay there more than, a certain period of time. But if you're doing education, or you have a work visa as a fellow, then it allows you to stay in a country for a longer period of time. And there's an advantage to that, because you really get to sort of experience it, as opposed to just traveling, which I think is also great.
Mhm.
But if you have the opportunity to educate yourself and work for a couple of years in a different country, um, I would certainly encourage that. I think it's very good for yourself, and growth, and having a global mindset.
Yeah, definitely. Now, I did want to ask a bit more about sort of the costs of this technology. Is access to orthopedic trauma care different for patients living in rural and northern communities compared to those in major cities like Vancouver, given the costs and limitations of this technology?
So yeah, certainly, um, like, these types of procedures are generally done in large centers. So basically in Vancouver, I think there's somebody in Victoria using it a little bit. Um, but if a patient is injured in a more rural area, then it does become more difficult. Um, and so sometimes patients, can't undergo limb salvage because of geographic reasons.
Mm. Okay.
And so, maybe AI could help with that. I'm not really sure. I just sort of thought about that, but maybe in the future, AI could help, bring this technology. The problem with this is we have to keep an eye on the patient quite closely. So usually these patients, I'm seeing them, once a week or once every 2 weeks. So if they live, in Fort St. John, it's just not practical for them to, either they need to stay in Vancouver for 2 years, but for them to go back and forth, it's just not practical. So there are geographic limitations to this.
Yeah, absolutely. Makes sense. What would you say is the most rewarding part of the job as an orthopedic surgeon?
Uh, I think bringing quality of life back to people is probably uh, what's most rewarding. And so, I would say, bringing people's quality of life back to them is probably the most rewarding part of orthopedic surgery. And whether that's trauma or due to degenerative conditions, or athletic injuries, um, it getting people back to where they want to be is probably the most rewarding part.
Yeah, so I'm just looking at the chat, and it looks like we did also receive another question earlier regarding immunization shots, because I know you mentioned tetanus shots. So they were asking what happens with a patient if they're not up to date on their shots because of their beliefs or religious beliefs, of not getting vaccinated. What do you do with them so they don't get infections or other infections that may arise?
So, really the only immunization in trauma that's important is tetanus. If they, if they don't consent to that, well then, that's their choice. In terms of staph infections, there is no immunization right now for staph infections. So you can only be immunized mainly for viruses. Viruses in certain, types of like mycobacteria like tuberculosis, but you can't for staph there is currently no vaccine.
Yeah, I am aware that you are a huge advocate on making global health more accessible for everyone, especially, within the Canadian community. What do you think we can do to relieve strain on the Canadian healthcare system in general?
Oh, that's a big question. Um, I think right now the main issue, specifically for me, my biggest issue is our wait lists and patients waiting a long time for surgery. And I don't know the solution to that problem in our healthcare system. Um, and so I mean there's an issue of needing more physicians, but in terms of surgeons, for instance, there are actually lots of surgeons who only operate 1 day a week or maybe 2 or 3 days a month. And so, it's a resource issue, and getting people operating time. And so I'm fairly lucky in that I have, pretty good access to an operating room. But we really need more resources in terms of, from an orthopedic perspective, more access to operating time for surgeons. And with that comes all kinds of other things, but yeah, that's a long question, long discussion.
Now, I did also receive just another question in the chat, coming back to the athletics, because I know there are some young athletes that are interested, in learning about, all this new technology and bone salvage. So, what is your experience with athletics, and if you've worked with any athletes who have had serious injuries, and what can athletes do to sort of prevent these sorts of injuries from happening?
So, I haven't had any, I guess, high level athletes that I've done a bone transport on that I can sort of think of off the top of my head. I mean, prevention strategies are, I mean, these are high energy trauma. So, the e-scooter, for instance, that's becoming a big problem. Like, so, they're dangerous. When it's wet here, it's slippery. It's difficult for vehicles to see people on e-scooters. They're fast. And so we're seeing lots of injuries from people using e-scooters. And so I would suggest to you that, if you're a high level athlete and you want to stay athletic, then probably using an e-scooter for commuting is, that would be one way, take the bus. Or find another way, because that's certainly you can prevent injury from that. We see lots of cycling accidents, so there's things you can do to help yourself not get hit, especially in Vancouver. We see a lot in the fall in November when it's dark early and it's raining. It's very difficult to see people. Um, these types of injuries typically don't occur from doing sport unless you're maybe, I guess, some kind of extreme athlete and you're skiing and jumping off of a 80-foot cliff or something like that, but I've not seen that. But these aren't typical athletic injuries. These are high energy motor vehicle an industrial or pedestrians being struck by cars type of injuries.
Yeah, for sure. Obviously, prevention is much better than dealing with the issues later on when they develop into, major accidents.
I think just in general, I have to say, orthopedics has been a very rewarding career for me, and we certainly need more people in healthcare. And if you're interested in healthcare, then um, it's a great profession. It's very rewarding. Um, I'm obviously biased towards surgery and orthopedics. It's a mechanical type of profession, and it allows you to use multiple different skills, and um, you operate on all different parts of the body, and I operate on children as well as adults and elderly people. And so, if you do have an interest in medicine and your heart's into it, then I would really encourage you to pursue that goal. And if it's not, being a physician, there's other ways to do it. So, I mean, there are engineers who invent these nails, and then there are business people who have to market them and sell them. And so there's lots of ways to be involved in medicine. And, it's a very interesting field, and things change all the time. Um, and so I'd encourage you to follow that path. It's really fun.
Yeah, that sounds great. I mean, I'm really excited about all this new technology, and orthopedics sound really cool. Who knows? I might go into that. But
Mhm.
I really appreciate your presentation today regarding all of this new technology, the tibial challenges, bone transport, osteotomy, limb salvage, bone elevator, new magnetic technology, everything. And thanks for answering all of our questions. And I really agree with you. Medicine isn't just limited to people who want to be a doctor, right? There's so many other engineers or business people behind this new technology that can be used to save people's lives and save their limbs, essentially. So we really appreciate, everything you've spoken to us today.
My pleasure. Thank you for inviting me.
This is the Youth Advocates for Global Health Association. Thank you once again, Dr. Viskontas, for sharing your insights with us today. And to our audience, thank you for joining us this afternoon. To register for our future events and to learn more about our organization, please visit yagha.org. Thank you.